I'll add my thanks for taking some time to come out and talk a little bit today about peripheral vascular disease. The term peripheral vascular disease simply means vascular disease that doesn't involve the heart. And it encompasses both diseases of the arteries, which we'll talk a little bit about, and the veins. The primary disease of the arteries is atherosclerosis, which is hardening of the arteries. And peripheral atherosclerosis is often associated with coronary atherosclerosis, all right? And it's also associated with diabetes, clearly associated with smoking. It runs in some families, and it's also a part of the natural aging process. Vein disease is also very common, and it's usually associated with poorly functioning valves within the veins or a history of blood clots. We'll talk a little bit about the circulatory system. The arteries carry blood away from the heart. That's what an artery does. It brings oxygen to the body, and arteries have thick muscular walls, while the veins, they carry blood back to the heart. They have very thin walls, and they carry CO2 back from the body. The circulatory system is just that. It's a circuit. And if you block the flow, either coming out of the heart or going back to the heart, you minimize flow in the entire circuit. So severe vein occlusions can be just as bad as severe arterial occlusions. We're going to talk first and mostly about peripheral arterial disease. And peripheral arterial disease, as we've mentioned, is mostly related to atherosclerosis, or hardening of the arteries, which is a buildup of fat and cholesterol within the arteries that narrows the lumen and causes a restriction of flow. That's one of the problems. And it also, these plaques here, they can occasionally rupture and spill all of their fatty cholesterol gunk out into the arteries. And when that happens, you can end up with a heart attack, a stroke, or decreased blood supply to some other important part of the body. Today, our topic is you can have peripheral arterial disease involve any part of your body. It can involve the kidneys, the arms, the eyes, the legs. We're going to tend to focus on the legs today. But the general principles apply anywhere in the body. It's important to understand that most people with peripheral arterial disease are asymptomatic. That means they don't know, they're not having any expressed problems. They don't know that they have this disease by the way they feel, okay? About 10 to 30% of patients, they present with what's called intermittent claudication. Claudication means pain when you walk, and it's a certain kind of pain. It's pain that happens at a certain distance almost every time. So someone will say, yeah, I get to the mailbox or halfway up the street, or you know, I can make it 20 yards, and then the pain. And then the pain starts.
That was painful.
With claudication, the pain stops when you stop. So when you rest, the pain goes away. And the term claudication comes from the Emperor Claudius, who limped. Okay, so that's where the term comes from. And then 1 to 2% of patients present with advanced limb-threatening ischemia and even gangrene, like we see in this top picture. Obviously, we want to try to catch peripheral arterial disease before it results in, you know, you've heard of a heart attack. Well, this is a toe attack. This is the toe not getting enough blood, and therefore parts of it die. A heart attack is where the heart's not getting enough blood and part of it dies. And here again, it's caused by this plaque buildup in the arteries that supply the legs. So peripheral arterial disease is a consequence of aging, okay? Almost no one gets out of this life with zero peripheral arterial disease. Although a lot of people make it through with with only a minimal amount. And again, how much peripheral arterial disease you end up with depends on your genes, your lifestyle, are you diabetic, have you smoked, etc., etc. Smokers, that's one of the biggest risk factors, probably the single biggest risk factor that we can control for. Diabetics, people who are overweight, males tend to get more atherosclerosis than females. People who aren't as active get more atherosclerosis. Hypertension and high cholesterol are certainly risk factors. And as I mentioned, there's some genetic predispositions. Peripheral arterial disease is very common. As we've already mentioned, people who have it are only diagnosed appropriately about half of the time. And if you have symptomatic peripheral arterial disease, in other words, if you have claudication or some other manifestation of peripheral arterial disease, then you have a significant risk of complications or even death within 5 or 10 years, okay? So it's not a trivial thing, all right? There's a significant incidence or association with heart attack. That's what MI is a heart attack, or stroke. We've already talked about claudication. That's one of the symptoms. We talked about the pain stopping when you rest. Numbness and tingling or weakness in the legs can also be a manifestation. We can see that with other conditions such as diabetes, but we do see it with peripheral arterial disease.
Would that be neuropathy?
Yes, it can. It sure can. So that's why the neuropathy is often associated with diabetes.
But I don't have diabetes.
But it's still, you're right, it can just be,
Yeah, that's what my doctor.
can just be neuropathy. If you have sores on the legs or feet that won't heal, that can be an indication, almost certainly is an indication of some vascular problem. Whether it's on the vein side or the artery side is something that we should figure out. People who have cold legs where previously they didn't have cold legs. If there's a color change, if the legs become more red or sometimes even blue. And then loss of hair on the toes or the feet or the legs can be an indication of vascular disease. Now, as we've already alluded to, not all of these symptoms always mean that you have vascular disease. You can have diseases of the spine, arthritis that narrow the canal of the spine, and that can cause similar symptoms. Peripheral neuropathy we just heard about. Herniated discs can cause what we call a pseudoclaudication. In other words, it seems like claudication, but it's really coming from a disc herniation. Arthritis. A Baker cyst is something where a fluid develops behind the knee, and that can cause similar symptoms. People with restless legs or leg cramps, those can all be confusers or imitators of peripheral vascular disease. So you'd say, well, how do you tell the difference? How do you diagnose peripheral vascular disease? Number one is to be aware of the problem. Okay, even a lot of physicians overlook the diagnosis of peripheral vascular disease. I've seen plenty of patients come in with some of the classic symptoms that we've just talked about, and their physician hasn't recognized that it's peripheral vascular disease. And a lot of that is not the physician's fault. There's the education of physicians doesn't emphasize enough the importance and the diagnostic considerations for peripheral vascular disease. So being aware of the problem is an important part of the diagnosis. A thorough physical exam. And then we're going to talk a little bit about a variety of non-invasive and even invasive tests that can be done to confirm that the symptoms that that a patient might experience or is indeed related to peripheral vascular disease or peripheral arterial disease and not one of those other entities that we were talking about. And it goes without saying that if you don't know what the problem is, it's hard to prescribe an adequate therapy. So it's very important to accurately identify the nature of vascular disease so that we can prescribe an appropriate treatment and to minimize the effect on patients' lives. One of the standby tools that we use, because it's very safe, it's portable, it's relatively inexpensive, is ultrasound. And it allows us to both diagnose initial peripheral vascular disease and to follow up on our interventions. In other words, if we were to do surgery or place a stent or do an angioplasty, we can use ultrasound to follow up those interventions to make sure that they're holding up over time. Ultrasounds can be performed without IV contrast or radiation. They don't need conscious sedation. Many of you have probably had many ultrasounds. They're not painful. All it is putting a little gel on the skin and putting a transducer, what we call a transducer or a probe, on the skin. The equipment is portable. We can do these exams anywhere in the hospital or even take the ultrasound machine out of the hospital if necessary. This is just an example of the Doppler signal that we get from an ultrasound. That gives us some information, and then here's what we call color flow, and that's showing blood flow within a carotid artery here. So we use a lot of ultrasound. We also use a lot of CAT scanning or CT angiography. All angiography means is taking pictures of blood vessels. So CT angiography means taking pictures of blood vessels with a CAT scanner. We have a wonderful CAT scanner here at Davis. We can get wonderful pictures of blood vessels, particularly the larger blood vessels in our bodies and our legs. It's minimally invasive. I've said non-invasive. It does require the placement of an IV, but it's just an IV. And then we inject some X-ray dye and take our pictures. It does use X-rays and therefore some radiation. And when we get these images, it allows us to do some very nice three-dimensional reconstructions, something that we have even a hard time doing with what we call a conventional angiogram. CT angiography is also very fast. We can get someone who presents in the emergency room, we can have a CT angiogram done usually within 15 or 20 minutes, no problem. Here's a picture of a CT angiogram. You can see the heart here, the aorta, the kidneys on both sides, the arteries that supply the kidneys. This is the artery that supplies the bowel. You can see it in the distal aorta here. The artery pooches out. Same with the you may not know what normal looks like, but there's also a dilatation or an expansion of the artery supplying this leg over here. And those are what are called aneurysms. We'll talk a little bit about those. But this is a nice CT angiogram. We can do the same thing with MRIs. So there's a CT angiogram, and this is an MR angiogram. MR angiography has the advantage of also being non-invasive or minimally invasive. It has an additional advantage of not using any radiation, doesn't use X-rays. So we like MR for that. It's safe to use for those who have X-ray dye allergies. Now, if you have a pacemaker, you can't go in the MRI generally, so it's not good for people with pacemakers. Some metal implants can't go into the MRI. So we have different tools, but you can see here are pictures of MR angiograms. Here's another patient with an aneurysm, but this aneurysm is in the thigh and just above the knee. But you can see how we see these blood vessels very nicely. Vessels that go out to the arms, vessels that go up to the head, all the way down. So these are examples of MR angiograms, ways that we look at blood vessels. Then we have what's called a conventional angiogram. And I'm an interventional radiologist. I do a lot of conventional angiograms. It's where we actually put a catheter into the blood vessel so that we can, that we want to image, so that we can inject X-ray dye and take X-rays directly. It's more invasive because we have to put those catheters directly into the artery, and then we have to move those catheters to the arteries that we want to take pictures of. It requires more expertise to do it safely. It requires someone who's had special training to do angiography. And the benefit of angiography is that it allows us to do things to the blood vessels to treat them, to put in a balloon to do something called an angioplasty, or to deploy a stent, which is a little scaffold that helps keep the artery open. It allows us to sometimes remove or dissolve blood clots. So we're often, in the modern era, we're often diagnosing with non-invasive or minimally invasive tests, and we're, for the most part, reserving conventional angiography to go in and actually fix things. This is a picture of a conventional angiogram. Again, we can see the aorta, the arteries supplying each kidney. This is the right leg, and you can see the x-ray dye is dark, and the highway down to that leg is open. If we go down the left leg, you can see the highway is blocked right there. So this person is having left leg pain, and that's the reason why. Now, all of the tests that we've talked about so far use imaging in some way, shape, or form. They all cost at least $100 to $300, all the way up to $3,000. Okay, so while they're not the most expensive things in the world, they're pretty expensive. We're going to talk a lot about a very simple test that does a very good job of diagnosing peripheral vascular disease, peripheral arterial disease, particularly disease that involves the legs, and it's called the ankle brachial index. And we all know what the ankle is. The brachial artery is the artery in our arm. So when we talk about the ankle brachial index, all we're talking about is comparing blood pressure measurements in the ankle compared to your standard blood pressure that you have taken in your arm. All right? It's a fancy term for comparing blood pressures up here to blood pressures down there. The other important thing to understand is that in normal patients, the blood pressure in your ankle is usually higher than the blood pressure in your arm. Okay? So we know that. What we do is we have the patient rest, and we use appropriately sized blood pressure cuffs. We measure blood pressures in both arms and both ankles. And the way we measure the blood pressure in the, particularly in the ankles, is we do it with what's called a Doppler probe. Instead of using a stethoscope, we use a little ultrasound probe that lets us hear when blood starts to flow in the artery. It's a little more reproducible, and it also lets us get specific blood vessels. There's more than one blood artery in the foot and at the ankle, so we get two separate measurements in each ankle. We get a blood vessel that supplies the front of the ankle and a blood vessel that supplies the back of the ankle. Just a picture. This is demonstrating the probe, and the probe is placed just over this artery. These arteries are pretty easy to find. Here you see two probes looking at what's called the anterior or the front tibial artery, and this is the posterior or back tibial artery. And then once we have all of those blood pressures recorded, what we do is we look at the highest arm pressure. So whichever arm has the highest blood pressure. In most patients, it's the same. But if you have a blockage to one arm, you may have a low blood pressure in one arm. So we use the highest blood pressure that we get from either arm, and we compare it to each of the blood pressures that we get in the ankle. And you can see here that if you have peripheral arterial disease, this simple, very inexpensive test has a 95% chance of picking it up. Okay?
Excuse me, can this be done by just a regular doctor?
Yep.
So you're, okay.
It can be, but I would say that the vast majority of the time it's not. It does require some specialized equipment. Most general practitioners don't have the equipment. And the other thing is that it matters how you do, it takes some practice. It's not difficult, but it takes some practice to do it so that it's reproducible.
Could this cause your ankles to swell?
This test?
No, this thing that you're talking about.
Yes, probably more likely to be on the vein side. And so far we're talking about the arteries, but it's more likely that ankle swelling is caused by either issues with your heart or issues with your veins. Okay?
Because I've had swelling in my ankle for a couple of years now, and I didn't.
Is it just one side?
One ankle is worse than, very much worse.
Yeah, it might be an issue with your veins. Is it your left ankle?
No, it's my right.
It's your right one. It could be any number of things. There's a lot of things that do it, but most commonly it would be something where your heart's not pumping as effectively as your body needs it to, or it could be problems with what we call venous insufficiency. All right? The other thing that I wanted to mention is that while it has a 95%, which is pretty good, chance of picking up that disease, if you have an abnormal study, it's 99% likely that the problem is peripheral arterial disease. That's also very good as medical tests go. The other thing that's important about this, if you remember, 50% of patients don't even have any symptoms. They don't even know they have peripheral arterial disease. And we know that peripheral arterial disease is associated with bad things happening, like heart attacks and strokes, let alone. It's inconvenient and it can be a real nuisance to have claudication. It's obviously a lot more than an inconvenience if you start to have gangrene in your toes. But just knowing that you have this disease can help tailor therapies that might slow its progress and minimize its impact, lessen the chance that you're going to suffer one of these catastrophic events. People who should consider having this are anyone over 50 that has diabetes or any of the other risk factors. They're smokers, they have high cholesterol, they have a family problem. Those people should start considering getting ankle brachial index tests done, okay? Then, anyone over 70 should have it done at least once, okay? Just to see if it's normal or not. If it's not normal, then it may be worthwhile checking into other areas where there may be problems. The carotid arteries, the coronary arteries, or the heart's arteries. If you have leg symptoms with exertion suggestive of claudication, no matter how old you are, it might be worth having this test done. And then if you have known peripheral vascular disease, it's worth having the test done every couple of years to see, is it getting better, worse, or staying the same? Now when we say open up a blockage, we will do an ankle brachial index and then we'll be able to compare it 6 months from now and see if it's staying the same. We are going to make an assumption that the intervention, the stent or the angioplasty or the bypass graft is doing well. Okay? You can see here that normal is a number greater than 1, which means that the pressure in the ankles is higher than the pressures in the arms. If you get to the point where the pressure is only even 90%, you may start to have significant symptoms. And when you get to below 0.4 or 40% of the pressure that's up in the arms, then you start to have issues with potential, your risk of tissue loss, limb loss, toe loss, goes up when you get in this range, particularly if you get below the 0.3 level. And if you're greater than 1.3, we see this happen sometimes. People who are diabetic, they get very, very hard arteries. And it makes it to where the blood pressure cuff can't compress them. And in these situations, this test is not a valuable test. All right? It's an artificially elevated number. we've talked about that. For those patients, however, we can do something called a toe brachial index, a TBI. And it's a very similar test, only instead of measuring blood pressures at the ankles, we measure blood pressures at the toes using very tiny blood pressure cuffs. Now, one of the reasons we like to diagnose peripheral arterial disease is because there are treatments for peripheral arterial disease. We like to modify risk factors. You've probably heard that term. All that means is those things that we can control, we try to control. If we're sedentary, we try to increase our activity. If we're smoking, your doctor's going to encourage you to stop. If you're diabetic, your doctor's going to encourage you to make sure your blood sugar is well controlled. There are medications to help with cholesterol. There are medications to help with blood pressure. We want to get all of those things as good as we can get them. Now, we can't control our genes, so that's not a risk factor that, at least currently, that we can modify. Now, once we've done the best we can do with what we call medical treatment, then there are interventional radiology interventions. Those are catheter type interventions where we can do angioplasties or stents or instill medications directly into the bloodstream sometimes to help with peripheral arterial disease. And there are surgical things that can be done. Sometimes the surgeons can go in and actually remove the plaque that's built up, or they can go in and do a bypass. They can put a different conduit that goes around the blockage. Okay, you've heard of a cardiac bypass. That's where a new vessel, usually a vein from the leg, is taken and connected from the aorta to a point beyond the blockage so that blood can flow. And increasingly, there's research into genetic-based therapies. We don't have great genetic-based therapies yet, but I predict that we probably will within the next, 5, 10, 15 years. Easiest thing, least expensive thing, is that regular exercise is good to, one, prevent peripheral arterial disease or minimize the risk, and two, it's a very good thing to even treat peripheral arterial disease. So a lot of patients with claudication, if they increase their activity level, they can get to where they don't have leg pain, and they might not even need any more treatment beyond that. You can see here, those who have taken part in a regular exercise program for 3 months have substantial increases in the distances that they're able to walk. I think probably everyone in this room has experienced, if you get in shape, you can walk further, you can run farther, you can do those things faster. Initially, 35 minutes of what we call intermittent walking. All that means is walk until you can't walk anymore, rest until you can start walking again, and then keep walking. Do that for 35 minutes. And then hopefully you build up to where you can walk all of those 35 minutes. And then add 5 minutes every session until you get to 50 minutes. And if you can do that 3 to 5 times a week, that's a good exercise regimen. So you don't have to run, you don't have to get out and do anything overly strenuous. You don't have to get on a Stairmaster or anything. You can just walk. You can do it in the mall. You can do it on a treadmill. And the only reason, one of the reasons treadmill walking is recommended is that you can always do it. Weather doesn't impact you, but you can do the same thing in a mall. A lot of folks like to do it in the mall. I would avoid a treadmill if you have any balance issues, those kinds of things. But walking is a good thing. Stopping smoking is a really good thing. That should be first on the list. It's not only going to help you with your peripheral vascular disease, it's going to help you with your lungs, etc. You can see here that people who smoke, they get hardening of the arteries or atherosclerosis a lot faster than folks who don't smoke. And stopping smoking is the single most important thing you can do to slow the progress of peripheral vascular disease. There are medications we talked about, lower your cholesterol, get your lipids in order to get your blood pressure where it needs to be. There are also medications that help the blood not to clot, okay? And then, but your doctor can help you optimize your medication regimen. Interventional radiology treatments are a host of catheter-based treatments. These treatments are administered by interventional radiologists like myself. Even some vascular surgeons do these types of therapies, and some cardiologists do these types of therapies, okay? You've heard of angioplasties. That's where we put a catheter that has a balloon on it where there's an area of narrowing. We blow up the balloon and it opens up the narrowing. Stents are like, for lack of a better analogy, they're like a chicken wire tube, only miniaturized. And they go in collapsed, and we expand them, and they serve as a scaffold to help keep the vessel open. Thrombolytic therapy is a fancy way of saying dissolving blood clots. Where blood clots form, blood can't flow. And so we'll go in and either take out or dissolve blood clots so that flow can be reestablished. We do that most critically in patients who are having strokes, because if the blood can't get to the brain dies, and when the brain dies, we lose a lot of functionality. I think you all realize that. So we use thrombolytic therapy for heart attacks and strokes frequently, because in both of those situations, it's critically important to reestablish blood flow as quickly as possible. Stent grafts are ways of doing bypasses inside the vessel. A graft, in other words, a bypass used to connect at one point of the artery and then bypass the blockage. Now we can put the graft in through the artery and deploy it, and that's what's called a stent graft. It's kind of like an internal bypass. We've talked about, there's catheter thrombectomies using catheters, so they're less invasive than surgery. But in certain circumstances, we still have surgeons actually open people up, open blood vessels up, and take thrombus or plaque out surgically. And then surgeons do bypass grafts. Here's examples. The greens are the blockages and the reds are the bypass grafts. You can see this is what's called an aortofemoral. So it's going from the aorta to the femoral artery, bypassing these blockages. This is a femorotibial bypass, so it's going from the leg to the foot. And here's a femorophemoral or iliofemoral. It's going from the right iliac artery to the left leg. And so you would do this because there's a blockage here. Blood can't get down there. So now this artery is going to supply both legs. Okay? These are surgical interventions. We're not going to talk a lot about gene-based therapy other than to say that it's being developed and that I think it will likely play a role in the future. We're going to talk a little bit now about non-atherosclerotic problems. There's aneurysms, and it's the most common lethal, killing peripheral vascular abnormality. And an aneurysm is where an artery bulges out more than 1.5 times its normal diameter. And these arteries only do that when they become weakened. And because they become weakened, why you die from an aneurysm is not because it's there. You die because the aneurysm ruptures and people bleed to death. Here's a picture. This is a normal aorta, and this is a picture of an aneurysmal or an aortic aneurysm. Okay, you can see how it's bulged out. Now this is a picture of a stent graft. You can see on the outside, this is the aneurysm, and on the inside, we've put a stent, and we call it a stent graft because instead of being open chicken wire, it's got a material on the outside. So it's like a real tube. And this is deployed, but this actually goes in collapsed on a catheter. It's a lot more narrow than this, so we can put it in here. And what used to have to happen before stent grafts, and what still occasionally happens when we can't use stent grafts, the surgeons would have to come in, clamp the aorta, clamp the iliac arteries, and actually sew a graft in there between those points. They would have to sew a graft in. This is deployed and the graft stays in place by a friction fit. You can see this metal framework expands and it stays in the vessel because of a friction fit, and it takes the pressure off of this aneurysm sac because the blood's going to flow through these tubes and not exert pressure on the aneurysm. Deep venous thrombosis. These are the blood clots. Someone says, I got a blood clot in my leg. 9 times out of 10, if not 95 times out of 100, what they're talking about is a deep vein thrombosis. It's a clot in the vein, okay? And we get these clots if we're not active enough, if we go on a long flight, we don't move our legs, etc., etc. And these clots usually form in the valves of the veins, and these clots can grow. And as they grow, they can get really big. Occasionally we'll see people with a clot that extends all the way from their knee to their belly button or even higher. And if that clot breaks off from the wall, it then follows the flow through the heart and into the lungs. And in the lungs, it causes, I'll use the term, a vapor lock. You know, the lungs, the arteries start to get smaller and smaller, and the clot can't fit through anymore, and the heart can't pump blood because the clots are blocking it, and people can die. That's called a pulmonary embolism. We'll talk about that in just a minute. That's kind of one of the worst things that can happen from a deep vein thrombosis. Deep vein thromboses can lead to chronic leg swelling, chronic leg pain, and leg ulcers, okay, so wounds that don't heal. So even if we get rid of a blood clot, that blood clot can cause damage to the valves that make the veins not work so well over time. It says if you have one clot, you may have as high as a 40% risk of having more clots in your future, okay? This is a picture of a vein. You can see the valves here. The valves keep the blood from flowing in the wrong direction. So blood can flow up through the valve, but when the blood tries to flow backwards, the valve stops it. Now, if that valve stops working for some reason, either because you just have congenitally bad valves, or a lot of women, their valves in their legs stop working well because of multiple pregnancies. But these clots can also damage valves, okay? So this is a picture of a DVT, or a deep vein thrombosis. We talked about pulmonary embolism when these clots go to the lungs. This clot has traveled all the way up and it's gotten stuck in this vessel here. If the clot burden is enough, it can block all of the output of the heart. And remember, because it's a circulatory system, if the heart can't pump blood, if the blood won't go forward, it locks up the whole circulation. This is a CAT scan. The white is X-ray dye, and you can see this black blood clot that's going into, this is the right lung, this is the left lung. These are blood clots that have made it all the way up and are into the lungs. You probably all know what a varicose vein looks like. A varicose vein is related to increased pressures in the veins that cause the veins to get bigger than they normally would. And it usually means that the valve in the vein is either absent or not working well. We have ways to treat varicose veins. The biggest way we treat them is to kill or remove the vein, okay? The good thing is we've got tons of veins in our bodies, so that if we take one vein out, there's almost always another vein to take over for it. And what we're counting on is that we're just removing the diseased veins and that there's enough good veins left to do the job. So sclerotherapy is a way we use a needle, put a little medication into the vein, and it kills that vein, okay? We use that a lot for spider veins, but you can use it for large veins as well. You've heard of laser therapy probably. That's where we put a little catheter into the blood vessel and a very fine laser fiber goes into the blood vessel. We turn the laser on and it cooks the vein. It literally fries the vein. But in doing so, it kills that vein so that blood's no longer flowing through it. And then blood has to take other ways back to the heart, and in doing so, it goes into veins where the valves are working properly. And then you've probably heard of vein stripping. That's where a surgeon actually just pulls the veins out. Okay, they're just literally stripped out of the body.
I'll call you in a couple minutes.
This is someone who has varicose veins. This is what they typically look like. Sometimes you can have varicose veins that you don't even see, though. We see women sometimes with varicose veins, or men that those varicose veins are in their pelvis, and you can't see those veins, but they still cause problems of achiness. This is someone who's been treated for their varicose veins. So to conclude, so we can maybe give you guys a chance to ask some questions. There's a lot of different forms of vascular disease. I didn't get too much into carotid disease. It's the same kind of thing, but carotid disease is a common cause of strokes. Coronary artery disease, which is a specific kind of vascular disease, causes heart attacks. We didn't talk too much about it. The good thing to understand is that almost all forms of vascular disease have some treatment that can help with symptoms or minimize the impact to your life. Doesn't eliminate it in many instances, but it helps. Revascularization procedures are how we do that many times. What that means is we get rid of blockages or remove blood clots. And it's also important to understand that, especially in the last 20 years, endovascular or catheter-based, so in other words, we're not doing open surgery, we're just making tiny little holes or punctures into the vessels and using catheters. These techniques are now being employed in almost all vascular disease situations. And the benefit of that is that you're not having major surgery. You're able to get back home, get back to your day-to-day living more frequently. That doesn't mean that there's still not a role for surgery. There absolutely is. But a lot of the things that we used to have to do with surgery, we can now do with less invasive techniques. Thanks. Any questions?